Hello everyone. Today we are going to talk about an important topic, that is acute mountain sickness and high altitude cerebral edema. Which is a common thing happens in patients or persons going for the trekking, or whenever they go and climb the mountains. Always there is a particular patterns everybody needs to follow, the speed at which they should ascend and all. So that has to be kept in mind. So as a physician, we should be aware of everything. Suppose anyone asks you on your clinical practice, or as well as for your theory exams as well. So first we'll talk about the physiology of high altitude exposure. So what happens when a patient ascends to the height? So that is very important. So for that, you should understand what is a barometer. So normally the air contains 21% of oxygen, and remaining is nitrogen 78%, and remaining is other small gases like ozone, carbon dioxide and all. So majority is formed by the oxygen and 78, then nitrogen. So whenever they compose the air, so they maintain a particular pressure at the level of the sea, which is considered as its baseline. So when we mention it is sea level, it is considered to be the pressure as 1 atmospheric pressure, or if you convert into millimeters of mercury, it is considered as 760 millimeters of mercury. An important thing you should also remember is something called as partial pressure. That means out of this 760 millimeters of mercury, how much is part participated or composed of by the oxygen, and how much is contributed by the nitrogen, that should be aware of. So as I said, it is oxygen is 21% of the air and 21% of 760. It comes around 160 millimeters of mercury. It's roughly around that. So this is the pressure, partial pressure of the oxygen at the level of C. So whenever any persons breathe it, so not, I'm talking about the normal person first, then we'll talk about the ascent. So in a normal person, when any person breathes air, so from the mouth to the airways, there is a trachea and then the bronchioles and the lungs. And inside the lung, there is called as alveoli. Each small chambers are the alveoli here. So from here, the pressure of the oxygen is 160 millimeters of mercury, and when it goes down, the pressure keeps decreasing depending upon the oxygen utilization and the pressure here. So at the level of alveoli, it is usually maintained around 95 to 100 millimeters of mercury. From the alveoli, the oxygen then has to diffuse and goes to the arteries. That is, it goes into the systemic circulation from here. So oxygen diffuses from here into the arterioles, and from this arterioles or arteries carry it to the tissues, and it goes into the venous circulation then. So in the capillaries or tissues or whatever the venous system is there, so basically here the partial pressure of oxygen is around 40 millimeters of mercury normally at the level of venous level or the level of tissue. So now whatever is the partial pressure of oxygen in the arterioles which enters here. So oxygen diffusion, so how much oxygen will diffuse into the tissue depends upon the gradient across this capillaries or across this arteriovenal gradient. So this pressure is usually around 90 millimeters of mercury. From alveoli, as I said, it is 100. From that to arterioles, it maintains 90 millimeters of mercury pressure, that is of oxygen. So since the venous system or the tissue has 40 millimeters of mercury, so there is a gradient of around 50. So 90 here and 40 here. If you subtract that, you get 50 millimeters of mercury gradient. And with this gradient, the oxygen start diffusing into the tissue and body starts utilizing it. So more oxygen get distributed into the tissue depending upon the gradient. Now, as you ascend, what happens is now the since go to the more height, this barometric pressure starts decreasing. So barometric pressure with more height, barometric pressure decreases, but the percentage of oxygen remains same, but the overall pressure starts decreasing. So suppose you go around kilometers or like I can say around 3,000 meters, that is around 3 kilometers height, the pressure will be somewhere around 523 millimeters of mercury. And if you climb more, that is about the Mount Everest height, the barometric pressure is only 253 millimeters of mercury. So now what happens is, suppose you climb 300 kilometers or sorry, 3 kilometers height. Now what happens is, if you consider that Initially it was 760, now it is around 560, and now 21% of this 560 will be the partial pressure. So that means that 21% of 560 is how much, as we can collect, and it comes to around somewhere around 80 or 70. So somewhere around 70 you get it. So that is 70 millimeters of mercury. And if you climb more height, this gradient decreases even more. So now if with this 70 millimeters of mercury, if the oxygen goes here, instead of 90, if this is 70 millimeters, the gradient now between the tissue and here is only 30 millimeters of mercury. So less oxygen goes into the tissue. And when lesser is the oxygen going, and lesser will be the activity and more will be the fatigability. So more fatigability will be there, and patient is not able to use the oxygen much. So patient will start breathing to the anaerobic system. So initially, to compensate this, what body tries to do is it increases the respiratory rate. That is a compensatory mechanism. Is the respiration start increasing so that more oxygen can be taken inside. So with this respiratory, so more oxygen comes inside, and CO2 gets washed out. So CO2 getting washed out is nothing but is called as the respiratory alkalosis. So whenever body is going to respiratory alkalosis due to the increase in the respiratory rate to take more oxygen, so to compensate that, what do is if your kidneys are functioning normally, these kidneys will now try to balance it. So to remove that alkalosis, what it does is it removes the bicarb. So if you remove more bicarb from the kidneys, alkalosis will revert and the patient will go into metabolic acidosis, or mild metabolic acidosis can be maintained by the kidneys through that. So this it is done by inhibiting the carbonic anhydrase enzyme, which is the enzyme which controls this H plus and HCO3 absorption. That is H plus plus HCO3 minus is equal to H2O plus CO2. So coming to that topic, as we have discussed, so body initially responds with a struggle response, primarily increased hyperventilation, which is the key mechanism, and it is mediated by carotid body chemoreceptors. So at sea level, it is 760 millimeters of mercury, and at high altitude, as the height increases, barometric pressure decreases, and partial pressure of oxygen will decrease further, and that is responsible for all the breathlessness and dyspnea symptoms. And this is what is called as, whenever this is there, it is called as hypobaric oxygen hypoxia, because the barometric pressure is down. It is called as hypobaric hypoxia. So to compensate that, there is hyperventilation, which causes increased washout of CO2, leading to respiratory alkalosis and dehydration. And in extreme cases, arterial pH may rise above 7.7. Severe alkalosis can actually suppress the ventilatory drive during the sleep time and lead to periodic breathing and may cause nocturnal hypoxemia. So during early acclimatization, when the patient or the person is climbing up, the kidneys tries to compensate by inhibiting the carbonic anhydrase activity, and thus more bicarbonate get lost into the urine, and it is compensatory, and it leads to what is called as, so there is excretion of diluted alkaline urine. So additional physiological adaptation which body adapts to this respiratory alkalosis or during acclimatization is increases the sympathetic nervous system, increases the erythropoietin level, which increases the hemoglobin, and this hemoglobin will indirectly lead to more oxygen carrying capacity to that. Also increases the capillary density in tissues and also elevates the 2-3 BPG levels overall leading to improvement in oxygen delivery to the tissues. So despite acclimatization, maximal exercise capacity decreases by approximately 1% for every 100 meters. So above, suppose you go more than 1.5 kilometer above the sea level, for every 100 meter you climb, 1% exercise capacity keeps reducing despite you practice how much of acclimatization is there. So if ascent occurs more rapidly, then the body can adapt to hypobaric hypoxemia, altitude-related illness may develop. So coming to that summary of the physiology of high altitude exposure. So decrease in barometric pressure is basically as you ascend height leads to decreased oxygen partial pressures, and there will be lesser is the partial pressure of oxygen, lesser will be the diffusion. And to compensate that, initial struggle response is hyperventilation will lead to respiratory alkalosis, sleep apnea, and hypoxemia. And to compensate that, there is renal raptation, that is increased alkaline urine, that is bicarb get excreted in urine, and decreased carbonic anhydrase activity. And other acclimatization methods is increase in erythropoietin and RBC mass, increase capillary density so that more oxygen get diffused, increase in mitochondria, and increase in 2,3-BPG. And all these things can lead to decreased exercise capacity and increased cold injury risk, may lead to altitude illness. So let's talk about two important terminologies. One is the acute mountain sickness, and the second one is high altitude cerebral edema. First, we'll talk about acute mountain sickness. It is a neurological syndrome occurring 6 to 12 hours after the ascent. Symptoms are non-specific. Most common symptoms is headache, and there could be nausea, fatigue, and dizziness. So mild form of ascent or this is called as acute mountain sickness, and severe form is called as high altitude cerebral edema. So you must differentiate acute mountain sickness with following symptoms, because this also may present with similar symptoms of headache, nausea, fatigue, and dizziness, that is called as dehydration, exhaustion, hypothermia, hyponatremia, and alcohol hangover. So coming to the risk factors, what are the major risk factors which is responsible for either acute mountain sickness or high altitude cerebral edema? The first one is the rapid rate of ascent. The most important one, the more rapid you ascend, more chances of acute mountain sickness, because body will acclimatize lesser. If there is previous history of altitude illness, the next time also there is high chances that patient will develop altitude illness. And heavy exertion. And if you do a severe heavily exertion, so always keep in mind slow and steady wins the race. So you should be slow, steady, wait, body to give time for the body to get acclimatized and then only climb. Poor physical fitness is not a risk factors for climbing in that. It's basically the rate at which you climb and how steady you are. So other contributing factors is the reduced cerebrospinal buffering capacity, sleep desaturations which may contribute, low ventilatory response to hypoxia, severe fatigue on descent. All these things are responsible. Children and adults are equally affected. Age more than 50 years are slightly lower risk because of the lesser metabolism in them. And there is no gender differentiations between them. So pathophysiology of acute mountain sickness and cerebral edema, that is increased hypoxia at high altitude, that is called as hypobaric hypoxia. This hyperbaric hypoxia leads to what is that to so that because now oxygen is not reaching to the brain, so body tries to compensate by increasing the cerebral blood flow. So more blood flow and more, and also because of this oxygen, body goes into this kind of stress and there is an inflammatory response, and this inflammatory response leads to increased permeability and thus leads to increased intracranial pressure and can lead to either acute mountain sickness, and if it is more severe can lead to cerebral edema because of increased interstitial edema as well. That means increased cerebral blood flow leads to increased leakage into the interstitial edema and cause acute cerebral edema. So high altitude cerebral edema is a severe life-threatening progression of acute mountain sickness. It is a severe end of altitude neurological illness. It is an encephalopathy. Patient will have ataxia, altered consciousness, diffuse brain involvement, and no focal neurological deficit. Other findings can be patient may have retinal hemorrhages and papilledema as well. And progression can be rapid and fatal. And risk factors remains the same: more rapid rate of ascent, previous history of altitude illness, and heavy exertion. Poor physical fitness is not a risk factor for it. So pathophysiology of cerebral edema we have already discussed above, like hypoxia leading to increased hypoxia and swelling. There is increased inflammatory response because of the hypoxia in the brain, which leads to increased permeability. More fluid leaks into the brain can lead to cerebral edema, and also because of increased intracranial pressure. So coming to prevention and treatment of acute mountain sickness and HACE, that is high altitude cerebral edema, how do you prevent it and how do you treat it if the patients get any of these conditions? So prevention is the main thing. The best method is gradual ascent. Do not ascend very fast. Most effective strategy. So whenever you reach around 3 kilometers of height, after that increase sleeping altitude by 300 meters per day. So that after 3 kilometers per day, you should only go 300 meters. Don't go more than that. After because the body will not getting acclimatized to that. So you give after 3 kilometers, give a gap of travel only for 300 meters and give a rest and you sleep and then you start walking the next day, and every third day you should take a gap. So 2 days you climb, you take third day gap. 2 days you climb, you take third day's gap. This will acclimatize the body, will get used to that oxygen levels and body get acclimatized to that. So spending one night at an intermediate altitude reduces risk. Prior high altitude exposure within 2 months reduces the AMS risk by around 50%. If you have any symptoms, do not ascend. Any signs of high altitude cerebral edema or high altitude pulmonary edema, you should immediately descend down. Always important is to maintain proper hydration, avoid both dehydration as well as overhydration. So pre-acclimatization, many of the trekking people or who do high altitude sports or thing, they do repeated exposure to hypoxia before ascent. Includes they go in hypoxic tents. There are ready-made chambers which are there, which are hypoxic. So to get used to that or acclimatize to that, they practice that and then only they go to that. So treatment based on severity, if only mild acute mountain sickness, mild symptoms are there, then you should only do is rest. If you have headache, you take analgesics, paracetamols or NSAIDs, and no further ascent is the thing. If you have moderate symptoms, then you have to, one thing is you have to descend by around half kilometer. Even half kilometer descent will also help you in getting acclimatized and to reduce the symptoms. Other thing is acetazolamide. So how does acetazolamide help is, as you all know that when you ascend to height, so the partial pressure of oxygen keeps decreasing. So at height, the barometric pressures are low, pressures is low. So the partial pressure of oxygen decreases. And this partial pressure of oxygen, when it decreases, what will happen is that body tries to compensate for by hyperventilation. This leads to increased CO2 washout. This increased CO2 washout will lead to respiratory alkalosis. And to compensate this respiratory alkalosis, then kidney start functioning. Kidney inhibits the carbonic anhydrase. And when the anhydrase is inhibited, more bicarb excretion in kidney excretion. More bicarb excretion occurs. When more bicarb excretion occurs, it will lead to metabolic acidosis. And this metabolic acidosis stimulates the breathing again. So if you stop inhibiting this, you have to inhibit this carbonic anhydrase, and acetazolamide inhibits this carbonic anhydrase so that more bicarb goes excretion and it can compensate and overcome this respiratory alkalosis. Supplemental oxygen if available. If patient develops early high altitude cerebral edema, what you have to do is you have to immediately descend. For edema to reduce, you can use dexamethasone, around 8 mg dexamethasone per day. You can use in divided doses, and oxygen can be given. And if very high altitude cerebral edema or emergency is there, you can use steroids, immediate descent. You can use high flow oxygen or hyperbaric chamber may be used. So what are the drugs in treatment of AMS? As we told, acetazolamide, the dose is 125 mg BD. It has role in moderate AMS but has no role in high altitude cerebral edema. Promotes metabolic acidosis and increases the ventilation. So acidosis increases the ventilation here. Dexamethasone 4 mg treatment dose, moderate AMS or high altitude cerebral edema, reduces the cerebral edema. Oxygen as available. Symptomatic reliefs and portable hyperbaric chambers, 1 to 2 hours pressurization. It gives a feeling of simulates the descent actually. And nifedipine and phosphodiesterase 5 inhibitors has no role in high altitude cerebral edema. Drug of choice is acetazolamide. It inhibits renal carbonic anhydrase. causes bicarbonate loss, leads to mild metabolic acidosis. This acidosis stimulates the ventilation here. So you have to do is 125 mg twice daily. Twice daily. You have to do start 1 day before ascent and continue for 3 days at altitude. Can restart if symptoms reoccurs and reduces acute mountain sickness risk by around 48%. Side effects is sometimes you get paresthesia, mild drowsiness, rare cases myopia, and low risk of sulfa cross reactions. So acetazolamide decreases the renal carbonic anhydrous, causes diuresis and mild leads to mild metabolic acidosis. This metabolic acidosis leads to hyperventilation, increased oxygenation and acclimatization, and reduces AMS incidence by around 48%. Dexamethasone maximum dose is 8 milligrams per day. Divided doses effective for prevention, should not be misused for performance enhancement. Other drugs which can be used but are not used routinely is ibuprofen 600 milligram TDS or acetaminophen, that is paracetamol. Hope you have understood the topic. If you have any queries or any questions, do comment in our comment box. And if you want more services of ours, you can make use of our question banks, which we have. So we have the question answers of last 10 years of all the medical branches in cardiology, general medicine, pediatrics, gynecology, and gastroenterology. For even for the DRNB levels, endocrinology, nephrology, neurology, we have. And also we do a lot of research work, research assistance, your thesis assistance, any publication assistance if you need of any of them. Thank you.